Welcome to today's LVAD web chat. Thank you for joining us for today's discussion about LVADs, left ventricular assist devices. My name is Ed Bottomley with the Michigan Medicine Department of Communication. We're going to introduce our three panelists in a moment, but first, a few housekeeping items. You can submit questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you could also send a private message to us via Facebook. If you can't stay for the whole chat or want to share the recording with a friend, a video of the chat in its entirety will be available on our Facebook page as soon as this one ends and posted to the Michigan Medicine YouTube channel soon after. So, on to our panelists. Cardiac surgeon on the far end, Francis Pagani, MD, cardiologist Keith Aaronson, MD, next to me, and both with experience in LVADs, and in between them, LVAD patient Mike Sovran, and they're all here with us, and let's open the floor to our questions. We have a basic question to start off with. What is a left ventricular assist device, or LVAD?
Frank, you want to show them over there? Sure. So this is actually a left ventricular assist device, but more to the point, a left ventricular assist device is exactly that. It's a mechanical pump that assists the left ventricle in pumping blood throughout the body. So it is not a total artificial heart. That's a different device in which the heart is largely removed, little bits left, and that pump, then the total artificial heart would do all the work. In this case, this pump does some of the work of the left ventricle. The left ventricle is still there, and the two can complement each other. There are, the original pumps actually took some of the blood from the left ventricle and stored it and then pumped it out. All the pumps, all the implanted, what we call durable left ventricular assist devices, which are pumps that remain in place for weeks, months, or years generally, are now continuous flow. So what that means is that there's something in here, an impeller that spins around. So blood, so this inflow cannula goes into the left ventricle, into the heart, and there's something that's spinning in here and accelerates the blood and then ejects it out this opening, which then would attach to the aorta, from which the blood can go to the rest of the body. And then here we have a drive line. So when Frank puts this in people, it sits over here, and then the drive line gets tunneled underneath the skin and exits usually over here or so, and then it has to be connected to both something smart and something with power. So we have here a controller, and a controller is really it's a little computer. So it's the brains of this thing. And then the other thing that has to happen is you have to have some way of powering it. So thanks Michael. Here's a couple batteries. So the batteries plug into here. And here's the two batteries. And so that's DC power. And then this also can be connected to an AC power source. So this allows you these batteries allow you to walk around and with Michael here. But then of course when you're sleeping, so these batteries last about 6 hours. If you're sleeping and the battery wears down, you have other batteries to change it to, but you won't have to get up, to change your batteries. So then these would be sitting in a charger, and then you can be connected to AC power so that you can sleep uninterrupted.
Okay, well, I appreciate that demonstration. It's very useful to have that there. The next simple question, or perhaps it's a complicated one, why does a patient need an LVAD?
The LVAD is largely reserved for patients who have advanced stages of heart failure. So the heart is very weak and no longer able to pump blood, and the patient begins to develop symptoms, shortness of breath and congestion, fluid builds up on the lungs. Patient begins to demonstrate evidence of swelling. That's advanced stages of heart failure. When cardiologists such as Dr. Aaronson are treating patients, the primary treatment of heart failure is medications. When those medications fail to treat the heart failure adequately, then the patient can be considered for a candidate for a left ventricular assist device.
Okay, we have a little bit of a follow-up question from there. Dr. Pagani, could you talk about the recent FDA approval for one type of LVAD, the HeartMate 3, which will provide a longer-term option for patients?
Well, currently there's 2 devices in the United States that have long-term approval. So the first one is which was approved a few years ago, was the Medtronic HVAD pump, and that's the pump that currently Michael has right now. It's right there. More recently, the HeartMate 3, which is manufactured by Abbott, was recently approved for long-term use. So the options now in the United States are that we have 2 pumps available, and the 2 major indications by which we use these pumps. One is we use them to bridge patients to a heart transplant. So if a patient has severe heart failure and we don't have a heart transplant available right away for them, then we could place a pump in and then bridge them to a heart transplant when one becomes available. The second way we use these pumps is if a candidate has advanced heart failure, but for one reason or another is not eligible for a heart transplant, then we could potentially put these pumps in for permanent use we call destination therapy.
Okay, thank you for that, Dr. Pagani. Mike, let's get you involved with a question here. Could you tell us about your journey to living with an LVAD?
I mean, like how I got it?
Yeah.
I was living in Chicago and working for an accounting firm, and my heart function kind of over the last 2 or 3 years that I was living there was kind of steadily declining to the point where it looked like I was going to need a transplant. So moved back home and came to U of M and was with the heart failure group for about, I'd say, 8 months, a year, and then got to the point where my function had dropped enough where I was a candidate for LVAD, and so I got the hardware.
Is your LVAD considered a bridge to a heart transplant?
Yeah. So I'm on the list, and have been on the list for about 3 years, and waiting for a heart.
Next question we have: how common are LVADs?
Well, I guess compared to what?
Yes, yeah.
So they're not nearly as common as heart failure is.
Okay.
So we think there's probably around 6.5 million people in the United States who have heart failure, and there's over 3,000 LVADs placed a year. So it's at this point it's a very small sliver of the population with heart failure. Most people, as Dr. Pagani said, most people aren't at this point sick enough. They're not severely ill enough to warrant a placement of a ventricular assist device. And then there are also patients who are sick enough from a heart standpoint, but are too sick from the standpoint of other illnesses. Surgery is a big deal, so they have to be able to withstand that surgery. And you want, you put a left ventricular assist device in somebody both to improve their length of life and quality of life. So obviously if someone is at very high risk for dying from the surgery, that wouldn't be a good idea. If they have some other illnesses that are really going to greatly limit their life expectancy, then it's probably a bigger hike than they'd want to take. Or if their quality of life is really impaired by other things, sometimes we wouldn't be able to improve it with a ventricular assist device. But with all those, if we reduce that 6.5 million by all those folks, there's still a whole lot of patients out there that probably would benefit from this technology were their doctors more aware of it and maybe had a better sense of what quality of life and life would be like on it.
And that quality of life question, that kind of brings us on to our next question. Mike, how did you feel before implants compared to now?
Much different. I mean, before I got my LVAD, I was kind of always tired. I could easily fall asleep watching TV and, wasn't all that active. Now that I've got the device, I can do, I can go exercise at the, cardiac rehab or the gym or whatever, and on the treadmill at home. I volunteer doing income tax returns every year, so I'm able to do that now, and it gives me a lot more freedom to kind of go out and do whatever it is I want to do.
Excellent. Next question that we have, is a heart transplant imminent after an LVAD?
Well, Mike could probably answer that one
Yeah.
better. He's been waiting a while.
Yeah, I mean, for some people, it is. That's the hope. If it's destination therapy, like Dr. Pagani was saying, then you're not getting a transplant. You're just getting the LVAD, and that's going to be what extends your life.
So heart transplantation in the United States is run by an organization called UNOS under a contract from the federal government, and there's a allocation priority system that's been developed, recently changed, that determines who's going to get the organs that are available. We have about 2,600 hearts available for transplantation each year. Whenever I get an opportunity to talk to people, particularly if it's more than one person, I like to point out that we can all do our part to make that number higher by signing our donor cards. One of my little buttons here is from Gift of Life there, yep. And probably more important actually than signing your donor card is letting your family know your wishes about this. The truth is that no one would ever take an organ, even if someone signed a donor card, if the family doesn't want it to happen. So it's really important to let the family know. We think that number could probably be at least doubled if more people sign their donor cards. Getting people who are on a ventricular assist device have a higher status than people who are on the list but are at home on oral medications. But the highest statuses are reserved for people who have a complication on the heart pump or people who require even more acute care than this. We really, sometimes I'm curious as to how you feel about Mike, but sometimes I think it can be hard for patients when they're waiting and dealing with that wait. And I think it's I always say to people that it's really important to think about being on the heart pump, kind of the way you're doing it is living your life, not living your life waiting.
Yeah, I mean, I guess you kind of feel like you're a little bit in limbo, because you don't know when it's going to come. You always hope it's sooner rather than later, but my experiences with the LVAD have been very positive. So, I feel like I've really been able to kind of do what I've wanted to do, or, I wasn't into any crazy adventure sports or anything like that before I got it, so I'm not prohibited. Yeah, so I'm not really prohibited from doing them now, but
there's no American Ninja LVAD warrior.
That's right. Yeah.
No.
Yeah. So.
Although I do know a guy who, not that this is necessarily recommended, but hiked to Everest Base Camp on one of the early generation VADs. So can be done. Probably not smart, but can be done.
Yeah, I probably wouldn't stress test the device that much, but
Yeah,
No, quite.
it's more being out in the middle of nowhere. I think is the
yeah, I
issue.
like to treat mine with kid gloves, you know, so.
Yeah.
Now, the next question, a little bit of a change of gear. Do I need to be on blood thinners if I have an LVAD?
Yes. And so when you receive an LVAD, it's important to be on blood thinners to prevent some of the potential complications of blood clots in the pump and stroke. And so patients require treatment with aspirin and a blood thinner called warfarin. And that medication has to be taken on a daily basis and actually requires periodic blood testing to make sure that the right dose of warfarin is being administered, and so that the balance between clotting and thinning of the blood is in the right range.
Thank you. And the next question, from moving on from there, where is an LVAD implanted and what types of incisions will I have?
The LVAD is implanted, if you envision the heart, it's implanted in, there's two major pumping chambers to the heart, the right ventricle and the left ventricle. The LVAD is designed to be positioned in the left ventricle, the main pumping chamber of the heart, and it's placed at the bottom of the heart, in which we call the apex of the heart. And then there's a tube, as it drains blood from the apex of the heart, there's a tube that carries it back to the aorta, and that's how the body is supported. The LVAD can be placed, it requires what we call a sternotomy incision, so we make an incision through the breastbone here, and requires that the use of the heart-lung machine. So while we're putting the device, attaching the device to the heart, the patient is supported by a machine that oxygenates and pumps the blood for the body. And then when the operation is completed, we transition the patient from the heart-lung machine to the LVAD for pumping of the blood. There are alternative methods to put the LVAD in. It could be placed through an incision in the side with a smaller incision up here, or other smaller incisions. So there's a variety of ways now that have been developed to place the LVAD.
So let's move on to some questions about living with an LVAD. Will an LVAD prevent me from doing certain things like exercising?
The only form of exercise I can think of that it limits you from is swimming. You know, you can't get in the pool, obviously, with a, electronic device. But I mean, walking on the treadmill, riding the bike, walking around your neighborhood, whatever you're doing, prior to that, jogging, whatever, you can still do. I don't really think there's any, real limitations. I mean, right after surgery, you can't lift too much because, of the sternum. Yeah, I mean, I can't think of any.
The only thing to note is that falling is not a good idea.
Oh, yeah.
Right, because you're anticoagulated, usually on antiplatelet drugs as well. We don't want that drive line to be displaced,
Tugged.
right? Because the skin kind of heals in around this line, which prevents bacteria from crawling from the outside into the body. So, we kind of stabilize that. We don't want people to fall. So, as long as you're doing things that don't lead to that. If I was skiing, it wouldn't be a very good idea. But Frank, he could ski just fine. He'd be perfectly fine.
No contact sports.
Yeah.
No mixed martial arts would be a bad idea.
And we have some other questions with relation to living with LVAD. You mentioned swimming. Can I shower with an LVAD?
Yeah, after a certain amount of time, you're allowed to, once you heal up from the surgery and I think can demonstrate that you know how to use the device and care for it properly, you do get a waterproof shower bag that the device and the batteries fit into, and then it's got like a rubberized zipper that, you know, keeps all the water out. So yeah, you can shower.
Control of the batteries.
Yeah, controlling the batteries go in the bag, and you know, then you just shower like usual, and
Some saran wrap.
yeah,
Oh,
and saran wrap over the bandage. But yeah.
Okay, and then with regards to work, your work life, do I have any limitations for working if I have an LVAD?
Well, I personally don't work. You know, I'm at a level where, you know, they determine I shouldn't be working and dealing with the added stress. I imagine you probably could work. I know you'd probably have to get somebody at the office tested or to check off on the how to, you know, triage the device if in fact there was an issue. But I think you'd be able to work with it.
Yeah. So I think, like you said, Michael, I think there's, so Michael alluded to having somebody else there who knows about how to deal with device alarms. We always like to have two people, you know, somebody else besides the patient, so that when there is an alarm notification, you can get some help, and just sort of two calm people thinking about things is always better. But yeah, obviously depends upon what job you're doing. You know, if you're working on bridge repair, it's probably not a good idea, but
Yeah, and there are a few more lifestyle ones. Am I able to drive with an LVAD? Is it safe to travel? What about airport metal detectors? Will I be able to have sex after I have an LVAD?
what's what?
Well, I drove here, so you can drive. What was the other one?
Travel, airport metal detectors.
Well, for me, travel really isn't much of an issue because I'm on the transplant list. I can't go too far from the University of Michigan. So I am pretty local right now. I imagine if you had destination therapy that you probably could. How it
People do
interacts.
all the time.
Yeah.
People take airplanes, and some people even travel to other countries. So it requires some logistical arrangements ahead of time, but it's all feasible.
So we will, in fact, you know, so if somebody's going, you know, we're here in Michigan, right? So people often go to Florida or Arizona, and, you know, we contact the centers there. And of course, you know, it's a small community. We know the people, these places, they know us, and, you know, it's pretty common for us to take care of. Just be there. I mean, not really doing anything most of the time, right? Just be there in case of an emergency or a question.
And we've
Very
had
common.
families that actually move. So they get an LVAD, and a few years later, for family reasons, they're moving to another state. And so they can move and travel there and start a new life.
Vice versa.
And vice versa.
Yeah,
And we've
people
had
come here.
patients come. So, and we know, again, we know centers throughout the country. They know us. And we're always exchanging, you know, receiving and giving up care of patients as they travel about with their normal lives.
Excellent. And then the other lifestyle one, is it safe to have sex after I have an LVAD?
Yes.
Okay.
Yeah.
And moving on from the lifestyle ones, charging the LVAD. How long does a typical LVAD stay charged? Do you have to have a backup battery power? And can you charge your LVAD outside your home?
Want to talk about that?
Sure. My LVAD, the hardware, doesn't really hold, I guess, what I would call a charge. It has to be connected to either batteries or AC power at all time. So we've got two batteries here, so like mine has both connected, and essentially it would drain from one battery and then switch over and drain from the other. So, you know, when one is low, then you would disconnect it, put on a new battery, and it would be pulling from this one, and then this one would go down, and then when it switches over, you would put a new battery on. So you're always got a charge. With the HeartMate, I believe that it has a battery in the controller, and so it actually, if you were to disconnect both batteries, although it would alarm, it would still be working. And so I think it's, what, 15 minutes? Yeah, that you can go without any battery power or AC power, and then so that one actually does hold a charge. But, yeah.
But the goal of that is just to provide an emergency. It's not meant to.
Yeah, it's not meant to.
It's not meant to. Yeah, it's just a safety backup, right?
And then the last lifestyle question, Mike, what is the hardest thing for you about living with an LVAD?
I don't know. I'm a pretty positive person.
Yeah,
I guess, you know, there's a lot of maintenance with it. You got to, you know, take care of the driveline site and, you know, always kind of make sure that you're trying to do the right things. You know, always making sure you got enough batteries with you. When you leave the house too, I mean, you've got 2 batteries connected to it, but you've also got to bring your backup batteries with you. So I'm always carrying batteries in a bag. But I mean, they're relatively mild inconveniences as far as I'm concerned.
Great. The next group of questions, we have a few questions about maybe some myth busting, some misconceptions. The first one, I've recently read that LVAD patients can now get CPR. Is this true?
It is true. Again, not something that you know, caused anyone great joy to have CPR, but there was concern that if patients underwent CPR, that you could dislodge the cannula, right? So you knock this out of the heart, and that's never happened. So in fact, people can have CPR. The question is, when do you get it? So, you know, if we grab Mike's wrist now, everybody's different, but there'd be not knowing anything about you, Michael, there's about 50-50 shot that you'd have a pulse or not. Because the way these things work, as I mentioned earlier, something's spinning around in here and it ejects the blood, so the blood is constantly flowing. And when you feel somebody's pulse, what you're feeling is the difference between the systolic pressure, which is the pressure that's generated when the heart beats and pushes that blood out, and the pressure that remains in the vessel when the heart's relaxed, right? Because of course there's always blood in your vessels. But with these pumps, you're just pushing out blood all the time, right? So, so now the heart's still there, so you could have some augmentation, but about half people don't have a pulse at all. So, you know, somebody shouldn't do, if somebody shows up in an emergency room and is not responsive, like it's certainly if somebody walked into Michael's room when he's asleep and didn't have a pulse, that would not be a reason to get CPR. It just means he's, you know, asleep. Right. So it's important that so you know we listen to see these devices. You can hear the hum when they're going. So you listen over the chest and see if you hear a hum, and if you don't hear a hum, then you know that's an issue. And obviously the person's not responsive. So you do CPR. If you hear a hum, but the person's blue and unresponsive, then there could be other problems, perhaps in the outflow of the pump, and we would do CPR if the blood pressure is low enough. And not only do you not have a pulse, but in many people you can't actually measure blood pressure. There's ways of doing it by listening with a Doppler, but if you just use a cuff and listen the normal way, you wouldn't get anything. So it's important to know when to do it, but certainly if you saw somebody who was down and unresponsive and not arousable and turning color like you would if you had no blood flow, then yes, you can do CPR.
Okay. The next one in this group of questions about myths and misconceptions, am I still on the transplant list if I get an LVAD?
Yes.
Absolutely.
Yes, you are.
Again, you know, it depends on the scenario. There are many patients who we put an LVAD in, who at the time we put the LVAD in, we don't think they're transplant candidates. So some patients may have poor kidney function, and actually putting an LVAD in can actually make them a transplant candidate. And vice versa, there are patients who we put an LVAD in for transplant reasons, but they experience a complication, and so we feel because of that complication they may no longer be a suitable candidate for transplant. So the status of the transplant status can change sometimes in some patients when they receive an LVAD.
That's fascinating. The next question under this category, what are the risks associated with an LVAD?
Well, the big risks are strokes, infections, or the pump clotting off. The pump clotting off problem has become less of an issue, although it still happens. But strokes and infections are big. And then the other is that we're augmenting the function of the left ventricle with a left ventricular assist device, but we're not augmenting the function of the right ventricle. And there's really a complicated relationship between the two. We have some tools that we use that are using clinical information to determine whether somebody is at high risk for developing bad problems with right ventricular failure if we put in a left ventricular assist device in early. So we exclude people from this therapy who we think are at very high risk of getting early right ventricular failure. We're not as good at figuring out about people who will have late right ventricular failure, and that's an area of active investigation right now. But I'd say those are the main problems with ventricular assist device therapy. And then, I'm sorry, I left one other one out. Another big one is bleeding, which is actually more common than all the things I just said. So there is a very high rate of gastrointestinal bleeding, gastrointestinal tract bleeding, and nose bleeding that occurs. It's in part relates to the fact that we're giving people drugs that make the blood not clot normally and make platelets not work normally. But it also has to do with a unique problem that occurs because of the way the blood is accelerated through these pumps. So in the different pumps, this thing is spinning in here at over 9,000 times per minute. And in the other pump, over 5,000 times per minute. So the blood is exposed to a lot of shearing, and that leads to a change in something in the blood that can lead to more bleeding. So there's this strange yin and yang in these pumps that they're both subject to clotting, and the patients are subject to bleeding. So getting that anticoagulation right, as Dr. Pagani was saying, it is critically important that we have people on these medications, but that we closely monitor them to minimize those risks.
Thank you. And as we're in the category of myths or misconceptions, are there any other myths or misconceptions that come up a lot that you guys encounter with regards to LVADs? Yeah, Mike, maybe.
Not that I can think of any myths.
Well, if you guys think of any, I'll always at the end wrap it up by saying, is there anything you guys think we've missed? So the next question we have, this is probably another Mike question. How long do the batteries last? I know we talked about batteries, but this one wants to circle back to that question.
So they're different between the models, but for the hardware like I have, each battery gives you about 4 to 6 hours. So the fact that you've got 2 batteries hooked up to it at all times, you're looking at about 8 to 12 hours of power. With the HeartMate 3, I'm told they get like 16 hours of battery life, because they're, instead of drawing on one battery completely and then switching to the other, it's actually pulling from both simultaneously, and so they're able to last longer.
Very interesting. The next question, actually this is talking about the process of getting an LVAD and what to expect down the road. We have a question for you, Mike, with regards to your positive attitude. What is your support system for keeping you successful and positive? Do you belong to a support group? Do you rely on family, friends, colleagues?
All of the above. So there's a cardiac support group here at the University of Michigan that is very good. They keep everybody up to date on all the changes that are going through and disseminate information very well. My family's been excellent. Both my mom and dad have helped and been trained on my device, and then actually in August my mom got an LVAD. So my dad has been trained now on both devices, so he's almost an expert. But yeah, I mean, family, University of Michigan, the doctors, both, surgical team, and everybody has been fantastic. Anytime I've ever had a question, I've been able to get an answer. The LVAD coordinators do a great job. I've been very happy.
Excellent. The next question's with regards to the process of getting an LVAD, what to expect a little bit down the road. So the first question under that category, how long is the implant surgery for an LVAD?
It depends on the patient characteristics. So some patients can have previous heart surgery. About 30 or 40% of patients might have had a previous history of heart surgery. So in those instances, the operation takes longer because we have to deal with scar tissue that forms from a previous operation. But generally, the operation in a straightforward situation is about 4 to 6 hours.
Okay. And the question following on from that for Mike, how long did it take you to adjust to living with your LVAD after you left the hospital?
I think when I left the University of Michigan hospital, I felt pretty comfortable with it. You go through a lot of training. They even take you on an outing, while you're under the care of, nurses and occupational therapy and everything, physical therapy. They take you out, kind of allow you to experience what it's going to be like being on your own, but having everybody kind of still there, which helps to kind of build I think some a little bit more comfort with the device and kind of what you're going to have to do. But everybody at U of M was really good about making sure I knew how to change my batteries. Any issue we had or could have, you were trained on how to diagnose it, how to do it, who to call if you didn't know how to do it. So I think I felt pretty good before I left, but I'd say probably within about a month, it kind of becomes second nature. I've always got it on my shoulder. It just is what it is now, so I'm pretty comfortable.
Yeah, and it is an adjustment, but with it come the positive aspects of having an LVAD too.
Well, yeah, you get to go out and do more things and experience more, and instead of being run down and tired at the house or whatever, it's nicer to be able to go out and do whatever you want to do, like go to a Tigers game or something.
Right.
Like you mentioned this, wearing it on your shoulder. One thing that's been really interesting to me is the different ways people come up with wearing this stuff. It's just remarkable. Right?
Yeah. So and again through the support group, there's all kinds of different ways that you can wear it. So I choose the shoulder bag. It works best for me. I just am comfortable with it, and my bag has a little window on top, so I can always look and see where I'm at or what the pump's doing. Or so I like that aspect of it. Some people, I know the fishing vests. They get fishing vests and
camera, photographer vests.
Right, and manipulate the pockets so that they fit the batteries and the controllers. When I came out of the hospital, I also had a belt option that you can wear that kind of puts everything. It almost looks like Batman's utility belt, So you can wear it around your waist, and that kind of evenly distributes the weight. I've just always had it in the shoulder bag and kind of liked it in the shoulder bag.
I don't know who she is, but there's some lady in northern Michigan who has a cottage industry making these vests that some patients really love.
Yeah.
And then there's
Oh
there's
yeah,
some
for
people
the
already, yeah, you know about that one?
yeah the HeartMate. They actually somebody designed like a workout shirt that has the pockets.
So it's like, I think it's for concealed weapons. You know, it's the tactical
Yeah.
shirts that they have. You know, so
Yeah.
instead of pulling
Yeah.
out your guns blazing, you pull out your batteries.
Yeah, so that's for the HeartMate. Those there's no like shirt like that for mine because with the HeartMate the batteries are
Longer cable.
have a longer cable, so
Yeah.
you've got more. You can cover more distance. With mine, you know, my battery can only go this far from the device. So, but I think it's just personal preference. I mean, whatever feels good to you. I know a lot of people like to put it in the vest or the belt so that it kind of distributes the weight more. Because the bag's about, I don't know, I'd say 5 or 6 pounds.
Okay.
So,
Next question with regards to the process of getting an LVAD. What is the recovery from an LVAD implantation like? What's the recovery like?
Well, generally, most patients spend about 2 to 3 weeks in the hospital. I generally like to, when I discuss the postoperative phase of the care with patients, I say the first week or two is recovering from the medical issues of having major surgery. And then patients are required to learn the device, and then the families are also required to learn about the device. And as Mike mentioned, we set up an outing where they go with members of the LVAD team, and then they troubleshoot. We go through algorithms for troubleshooting different alarms. And so it takes about a week of education working around family schedules and patient schedules and things like that. So generally it's about 2 to 3 weeks in the hospital.
With regards to complications, what kind of complications should I expect with an LVAD after surgery?
Well, Dr. Aaronson already mentioned some of the major complications. There's other complications that go along with any open heart surgery. So any time we do a major open heart operation, such as a valve replacement, bypass operation, so there are complications such as that, a pneumonia, urinary tract infection, things that are typical of any operation that we do. And then Dr. Aaronson mentioned the ones that are more specific to the LVAD itself, the bleeding complication and the potential for stroke and so forth.
Mike, 2 questions for you. Did you have or experience any complications from your LVAD surgery? And have you had any equipment issues or concerns since your LVAD has been implanted?
no, I didn't have any complications after surgery. Everything went fairly smoothly with me. As far as device issues, I also didn't have any of those. My mom didn't have any either. Everything's been very smooth.
And the next question, we've touched on this a few times. Will my caregivers get special instructions about my LVAD?
Absolutely.
Yep.
So we'll go through, there's actually tests, and we have to check off lists that we go through before patients get discharged from the hospital. And then there's always frequent refreshers if we perceive there's issues or patients ask for further
Somebody else
training.
comes into your life,
Right.
We
Right.
educate them.
Yeah. Great. In terms of, is it possible for an LVAD to malfunction? If so, what steps need to be taken?
Yes, the pump can malfunction. There's 2 major ways a pump can malfunction: through electrical problems or mechanical problems. And the major mechanical problem is if a blood clot develops in the pump. Electrical problems are very, very infrequent with the more modern or the devices such as the HVAD and the HeartMate 3. The main concern is pump clots, which we could result, if a pump clot does form, could result in a need to change out the pump.
Okay. And then another question, I've heard of LVAD patients needing blood transfusions. Is this common, and if so, why?
Yeah, I mean, it's not uncommon. So the transfusions result, well, there's some transfusions that would occur during the operation, right, because it's a big operation. And certainly if you've had prior heart surgery or surgery within your chest, as Dr. Pagani mentioned, there's a lot of scarring, and so cutting through that scarring to get access to the heart can be even more bloody. So those people are more likely to need transfusions during surgery. And then following surgery, if they have gastrointestinal bleeding, some people will need to get transfusions. We try to avoid transfusions in general, and we particularly try to avoid transfusions in people who are on the list for a heart transplant, because when we transfuse blood, the patient runs the risk of developing antibodies against markers on the cells on those blood cells that come from other people, right? So we all have markers on our cells that identify the cells as being ours or not ours, and if you develop antibodies against the not me, then those same markers exist on all the other organs. So if you have antibodies against, if I was a heart donor and Michael has antibodies against what's in me, he's not going to be able to get my heart. I'm not giving it up at the moment, but just for information's sake.
Another viewer question, is it possible to get an internal infection with an LVAD, and how do you deal with it when the antibiotics don't work?
Yes, you can develop an internal infection and the first line treatment would be antibiotics, but if they did not work, sometimes it requires the pump to be removed and replaced.
Or, the other thing is that it does actually, if that happens, that's one of the things that moves you way up the list to get a heart transplant. So the best therapy for certain types of bad infections in an LVAD is actually a heart transplant. It's one of those strange things where obviously you don't want this thing to happen, but if it does happen, it's good that we have the opportunity to get a heart more rapidly for someone like that.
And the next question, which seamlessly follows on from that question, can an LVAD be removed, or is it there for life if I'm not a candidate for a heart transplant?
Well, there's one of the serious things, decision processes with an LVAD is when we talk to patients, it's not like the LVAD treatment is not like a pill. If you don't like the pill and you have side effects to the pill, you can stop taking the pill. With an LVAD, if you receive an LVAD, there's not many options if you if your lifestyle changes and it doesn't change to the way you expected it. There are patients, obviously, who have the pump removed for a transplant. There are a much smaller fraction of patients that actually, when we put the LVAD in, it allows their heart to heal and the heart function returns back to near normal. And under those circumstances, we could safely remove the LVAD, and actually those people are left with near normal heart function. But to remove an LVAD in somebody whose heart function remains poor, that operation is unlikely to be successful.
And then moving on from that, the next question that we have, how long does a typical LVAD last?
Well, an LVAD, we've had patients out 13 years on an LVAD. So it's potentially decades.
Yeah.
'Cause
And that was the follow-up question to that. How long can a patient live on an LVAD?
we don't really know. It depends. A lot will depend on the technology. As the technology gets better, we're envisioning people living decades.
So it's a little hard. The reason it's hard to answer is that if we showed you at the first commercial LVAD looked like. It was totally different than this. It was something that looked kind of like a flying saucer. That was about. Do we have one? The original?
Oh,
No. That's so the one you have there is later.
We can move that into the camera
let's move
just to
that
show
into
the
camera.
progress.
Right. So this is a second generation device, okay, but the first generation device would be literally, if this is the size of this LVAD, the first generation device was about that big, like that, and it was not continuous flow like this. It was pulsatile, so blood would enter one side, and there was a pusher plate here, either powered by air initially and later electrically, and that pusher plate would move up and down and eject the blood out. It was much, much bigger. It took up a huge chunk of and it worked completely different mechanism, and frankly, while it was it was the first, a huge advance, they tended to break down at about a year and a half. So, these, the HeartMate 3 we just mentioned was just, only approved in the last couple of years, and the HVAD has, been around for only about a decade. So, to be able to say, how long can people go, it's too early to know. And obviously there are ongoing improvements in technology.
Mike, how long have you had your LVAD?
I've had mine for almost 3 years.
Next question that we have, how do you address, and I think we touched on this a little bit, how do you address infection risk with patients?
We have, in terms of the right during the operation and shortly after, obviously we administer antibiotics and have processes in place for sterile treatment, obviously during the operating room and shortly after that. When patients go home, the major risk is the infection at the site where the driveline exits the skin. And as Mike alluded to earlier, there's ways of changing that dressing. There's a special type of dressing that you apply to that. And you want to make sure that that dressing is clean and applied properly as directed. When you shower or bathe, you don't want to have water touch that site, because water actually has very bad bacteria in it. Tap water has bacteria in it. So you want to avoid tap water contaminating that site. And then the most important way of preventing infection is preventing trauma. So you don't want to pull on the driveline. And then the other routine things such as dental cleaning to make sure that you don't have bloodstream infections from poor dentition or dental abscesses.
We actually have a pretty large grant to try and investigate what leads to differences in infection rates across different institutions. So we're really trying to learn more about this now.
That was an excellent question. Thank you for that. What does it mean to be an LVAD Center of Excellence?
I think it's important. A lot of those designations are made by third-party insurance carriers. So obviously those are important to be viewed by our insurers that we're delivering great quality. But I think it really, the major issue about LVAD therapy is it requires a very dedicated team model. And so although we work very closely the medical side and the surgical side to provide the care, the core of this, really what makes the mold, is our VAD coordinators. And they become great friends with the patients, and they're constantly on a phone with the patients. They're seeing patients constantly in follow-up. And this group is a small group of people that have phenomenal expertise. They've seen it all. And really, that really provides the center of excellence.
And if I can add to that, we have biomedical engineering specialists who look through these devices and see that everything is working. We have We have pharmacists who specifically manage the anticoagulation on these patients, on our VAD patients, so that we can have the greatest likelihood of keeping them within this narrow range that we want them to be in. It really is very much a multidisciplinary effort, certainly without a surgeon, none of it happens. But without the rest of the team, what would happen later wouldn't be so good.
So as we come into the final 5 minutes, I always like to try and wrap things up, see if there's any more advice or anything like that, squeeze as much information as I can out of our experts here. So Mike, for you, my questions are, do you have any recommendations for new LVAD patients? And is there anything else you think is important to note about having an LVAD? Is there anything else you'd like to share that you think we might have missed?
Just kind of do what you're told. Don't do anything that's going to put the device in any kind of danger or damage, and follow the instructions that you're given. And, the team here at U of M, like Dr. Pagani was saying and Dr. Aaronson was saying, everybody has been very good and very helpful. And so, when they give me advice, I want to follow it. What was the second part of your question?
The second part was, first part was recommendations for new LVAD patients, and the second part, is there anything else you think that's important to note about having an LVAD?
I think if you're a candidate to get one and you're on the fence, I would say get it. I have been able to do a lot more since I got my LVAD, and have a little bit more freedom and able to do, kind of more normal stuff than I was doing. Prior to the LVAD, like I said, I was, tired a lot, and, now I'm going to ball games with my dad and, kind of going wherever we need to go. So it's been a good experience for me.
Here's your question, Mike. If you were to rate your quality of life from 0 to 100, 0 is the worst thing you can possibly imagine, and 100 is nirvana, where would you say it was before you got the LVAD?
I'd say it was like in the 40s or so.
And where would you say it's now?
In the 80s.
So, in the national surveys, the average level, average rating before people get an LVAD is somewhere in the 30 to 40 range, and the average afterwards is somewhere in the 70, 75 range. So you're doing really well, but most people do well,
yeah.
Right? And I think that's kind of the really important message here is I think it's easy for, if you don't know about this and you're hearing about it for the first time, or you've heard about it but haven't really seen it, you'll look at all this hardware and driveline batteries, etc. I think it can be overwhelming, and it can be difficult to imagine that you get all this stuff, and yet, plus we talked about complications, to imagine that you're really going to have an improvement in quality of life. But those surveys are all comers, right? So it's including people who have never have a complication, people have plenty. It still ends up averaging out into the low 70s. Most people feel a whole lot better afterwards than they felt before. Some of that selection, right? I mean, if you took people who were at 70 before and they're still at 70, I don't think you'd think it was a great shakes. But I think I've certainly been impressed that if you're careful in selecting the right people, most people really do feel a whole lot better afterwards.
Fantastic. I mean, you know what? I think that's a perfect time to wrap this up. If we've missed any viewer questions, we have run out of time, but we'll respond on Facebook. I'll ask you guys these questions and we'll get them responded to after the Facebook Live closes down. So we're closing in on the end of our chat. Dr. Pagani, Dr. Aaronson, Mike, I think your perspective has been really valuable. Thank you as well for bringing these. It's been really fantastic to be able to see the progress as well. And if you're interested in sharing this recording, if you tuned in a little bit late, you want to see the whole thing, it's going to be on Facebook Live, our Facebook page, and on YouTube as well shortly thereafter. So thanks to our experts, and thank you to our viewers for joining us today.
Thanks, Ed. Thank you.
Yep, thank you.
Thanks, Mike.